I'm feeling slightly hard done by. Last year I had models and everything. and now I've got to talk as a surgeon after you've had the oncologist all day yesterday. I promise no words ending in nib or nab. So completion lymphadenectomy is actually a hot topic at the moment. Sorry, I'm a plastic surgeon in Oxford, and I've been looking after melanoma patients for 15, 16 years now. So it's such a hot topic that I've sat through 2 talks that I'm about to give to you, one by Mr. Peter Budney, one by Professor Mark Moncrief, both excellent surgeons who I would be very happy if they looked after me, and both of whom, when I said, could I borrow your slides, just ping them across straight away. So you're having 3 surgeons' opinions, and so most of these slides are a combination of those 3. There has been a whole melanoma-focused consensus meeting on what we should be doing in terms of completion lymphadenectomies, and the results of that are not out yet, but they should be published soon. So it is a hot topic. Just to go back to the basics, a sentinel node biopsy is when you selectively remove 1 or 2 lymph nodes. A completion lymphadenectomy is when you remove everything in a nodal area, leaving behind the important structures like nerves and major blood vessels. So you don't pick out the odd node, you take everything, skin, some skin, but mainly fat and lymph nodes and the vessels in between. So a completion lymphadenectomy, which some of you may have had and certainly had talked about, is the more radical procedure. But I am going to talk about sentinel lymph node biopsy because this is the 21st century. And I've got a few bugbears, and I'm slightly disinhibited because it's a Saturday morning, so I hope I don't cause offence to anybody who watches this, mainly my colleagues on YouTube or whatever it is later. So as Rebecca pointed out, this is the current NICE guidance. We only published in July 2015, so that's only 3 years ago, and we're already talking about this being sort of vaguely obsolete. But do not offer of 1 millimetre or less. So as you can see from what Rebecca has said, that realistically we should be offering sentinel lymph node biopsy to any melanoma of 0.8, and we've looked at all of our data in Oxford and we found exactly the same. It was about 7.6, so about 8% of people who had the new stage 0.8 to 1 millimetre were positive for sentinel lymph node biopsy, and less than 0.8 we were down at 3 to 4%. So our data backs all of that out. So everyone who has a melanoma of over 0.8 millimetres should be offered a sentinel lymph node biopsy. This is interesting, we'll talk about it later, but it's only a staging investigation rather than a therapeutic procedure. And so this is what Rebecca pointed out, use 0.8 rather than 1. So this is it. This is the guidance. Consider sentinel lymph node biopsy greater than 1 millimetre. Give detailed verbal and written information about the advantages and disadvantages of each of the techniques. So this is what you should be expecting. You have a melanoma over 0.8 millimetres, you should go and see your physician, and you should be given a detailed discussion and verbal and written information. So this is the current position in 2018. A significant minority, probably up to 20% of people in this country, are still not offered sentinel lymph node biopsy. This situation is worse in the head and neck. And the various reasons given, it's not funded, the CCG don't fund it, it's serious complications from this procedure. It's too difficult to do it in the head and neck because there's blood vessels and things, and we don't do it here. These are the sort of excuses that are given. I sort of tailored this down. Here's a few responses I thought you could give. So if you're told that, please refer me to a centre that specialises in sentinel lymph node biopsy. I wish to discuss all my treatment options. You should be discussing your sentinel lymph node biopsy with a surgeon who carries out that technique. So if you get somewhere and you've got a melanoma of the head and neck and they say, oh, no, it's very difficult, complication rates are too high, you could say, well, just refer me to a better surgeon then and I'll do that. But that's probably a bit iffy. So then what you could say is, please refer me to a centre that's specialised in sentinel lymph node biopsy in the head and neck. I understand that the complication rate and success of the procedure is considerably lower than for other areas of the body. And we've just looked in Oxford at all of our data done by 3 head and neck plastic surgeons who specialise in that, and the complication rate and the are less than for any other area. Long-term complication rates, I won't use the term naught, but let's say less than 1%. So it's a very safe day case procedure. So that's not what I was supposed to be talking about, but I'm allowed to go slightly off cue. So sentinel lymph node biopsy in this country, we should be offering it, everyone should be offered it, particularly now, because we're about to talk, you heard yesterday, about all the wondered things that might be brought in for people with a positive sentinel node biopsy. We've got to get there. So this is the big area of debate, okay? So people who are sentinel lymph node positive, what do we do in this situation with probably the advent of these adjuvant immunotherapies, no nibs or nabs there, yeah, immunotherapy treatments, okay? So if you, and this is still an extremely good table. This isn't a nice guidance, you know, the advantages of doing a completion lymphadenectomy versus the disadvantages. This is extremely relevant. If you've got palpable nodal disease, i.e. you come in and you feel a lymph node, then I don't think the situation's currently isn't debated about what you should do. If you've got disease in the regional lymph node basin, then you need to do something about it. So we're not worried about that or talking about that. We're talking about this group. What happens if your sentinel lymph node biopsy is positive? A few things have been talked about about surgery and things in melanoma, and we've got to remember that there have been, you know, I am more than delighted as a surgeon about the advent of the immunotherapies, because when I started off, I remember Professor Middleton, who spoke yesterday, and we had our little melanoma group. There was 4 of us sat there, and he sat in the corner looking even grumpier than normal, going, well, I've got nothing, don't talk to me. But in effect, there now is something, and there's a lot of very good something. So that's really exciting. But surgery still has lots of important points. It's a local regional therapy. So obviously, if you take your lymph nodes out of the groin, you're not doing anything with the lung. You're just doing local regional treatment. It only affects the area of the area treated, and what we're mainly doing with surgery is preventing loco-regional disease. But if you prevent loco-regional disease, it can have an effect on overall survival, and certainly disease-free survival. If you've got a lot of bulky nodes in your neck, then that will affect your survival. And there are groups of people, all the studies I'm going to talk about, and you've heard talked about, they're big studies. They all have, certainly the surgical ones have flaws, but they're not individualized. They try and remove the individual data by having lots of people. But there'll be subgroups that will benefit from some things rather than others. Okay, so this is the point we're saying. 80% of patients undergoing sentinel node have negative nodes. Only a subset of people benefit from nodal surgery, okay? And some people have just got systemic spread, and you're not going to cure them at all. We don't know specifically who's going to benefit from completion lymphadenectomy, but we do know what the outcomes of 2 big trials are, and I'm about to show you those next. So this was the first study that you've heard about. MSLT are the studies, you know, the 2 big studies that have been done, and the first one suggested, well, this was observation versus doing sentinel nodes. So 2 groups of people, one will watch, see what happens, one will do a sentinel lymph node biopsy. And they basically found that really the regional control rate was much better. So as you'd expect, if you had lots of surgery on your groin or armpit or wherever it was, you didn't have recurrence in that area. It gave good information. And there seemed to be a very small but limited survival benefit for the 1 to 4 millimeter group, what we call intermediate. So this then brought up this trial called MSLT2, which basically was comparing doing completion node dissection or not, okay? So the advantages were that we're going to remove more cancer, get more information. Potentially, if you knew more information, you could get entry into clinical trials, and you get better regional control for doing it. But as we know, most completion lymph nodes are negative because 80% didn't have anything more to do. There's more complications because of lymphedema and nerve injury, and the disease may already be around the body, so what's the point of doing it anyway? And then you have this other option called ultrasound. So why bother doing the completion lymphadenectomy if you could just say, well, you're sentinel node positive, we're going to put jelly and a probe on the area every 3 months and check things out quick. And if we see anything changing, we'll get in then, but we won't do it straight away. And essentially, this was the end point. This is the whole point of MSLT2. Basically, between the two groups, there wasn't any significant survival difference. So somebody sentinel node positive doing a completion lymphadenectomy didn't improve survival over not doing a completion lymphadenectomy. At the same time, they did this other study, slightly smaller study, well, a lot smaller study called DCOG in Europe, and that was their outcome, okay? Complete lymph node dissection versus no dissection in patients with sentinel lymph node biopsy positive melanoma. No survival difference, 3 years. So, everyone grouped together in all the studies that have been done, and to be honest, there are deep flaws with both studies, in my opinion, but they're the best we're going to get, so we're going to live with it and say we're not going to repeat these studies. So this data says that. So it would be difficult, these are a few opinions we got. Merrick Ross, very well-known surgeon in the States, it would be difficult to endorse the practicality of routinely recommending completion lymph node dissection, and therefore these trials results should be practice-changing. So that's the general opinion. What is interesting is, remember I said before, oh, this is just a sentinel lymph node biopsy is just a way of gaining information. What people are saying now is actually doing the sentinel lymph node biopsy may be a treatment. You don't need to do the completion, but if you do the sentinel node biopsy and you take out the lymph nodes that have got cells in it, is that a form of treatment? So we've moved from sentinel lymph node biopsy from being investigation to is it possibly becoming a treatment? Ultrasound surveillance. So this all sounds rather good, doesn't it? We'll talk about that later. But you might consider doing lymph node dissection in certain cases. So that's one opinion. However, another eminent surgeon says, I would advocate complete lymphadenectomy for accuracy of staging. Patients want to know their risk. So hang on a minute. I thought we were doing the completion lymphadenectomy to cure people, and now we're going to be doing it for staging, because I want to take you back to Roberta's slide on the ends. The ends depend on how many nodes you have with disease in it. If you've done a sentinel lymph node biopsy and you've got 1 node positive, and then you do a completion lymphadenectomy and another 4 nodes are found to be positive, that changes your end status. So now people are saying, well, actually, if you do the completion lymphadenectomy, that gives us some information. So that's becoming the investigative tool, not the curative. So I hope this is right. I got pretty confused on it all. I've listened to a talk twice. I'm getting there now. I think I'll have it a couple more times and I'll be there. So, but basically, this is the point. The number of nodes changes your stage. And the only way you know about the number of nodes is if you have them all removed or if you have a huge number taken out of your sentinel node biopsy. But the average number of nodes removed in a sentinel node biopsy is 1.7, between 1 and 3. So most people don't have this sort of information. Okay, but there are a few things that we need to think about. At the end, I'll say this, but having a completion lymphadenectomy, the option of surgery, is a personalized decision. There are a lot of factors. And as a patient, you should have your options discussed. It is a medico-legal entitlement to have the options for your treatment discussed. That is it. Not told what to do, you should be told what your options for treatment are. And there are a few things that this is basically, this stuff means how big the deposits are in your lymph node. So if your sentinel node is positive, have you got 1 cell in there? Or have you got a clump of cells that measure 1 millimeter or a clump of cells that measure 2 millimeters? Or have you got lots of clumps of cells? Sort of makes sense, doesn't it? It indicates the activity of disease in the lymph node area. And so this group here, these colours at the top, do better because they've got less disease in their lymph nodes. These colours at the bottom do worse because they've got more disease in their lymph nodes. Fairly logical. So if you're sat there, and I'm sat there with somebody in front of me who's got one cell in one lymph node, and then second node is negative, I'm pretty reluctant to be talking about any form of major surgery. If I'm sat there and I've got somebody who's got 2 lymph nodes positive with lots of disease in both lymph nodes, then their chance of having problems in that area again has got to be higher. So the MSLT studies, the study we're basing all of this chat on, had lots of exclusions. They didn't look at these things, extracapsular spread where there was melanoma going outside the lymph node. They didn't look at these things, the in-transit metastases, the microsatellites that Rebecca talked about. The lots of people excluded. So we don't know in these groups necessarily what the outcomes are with or without surgery. An extracapsular spread where you've got, as you'd expect, where you've got stuff trying to escape from the lymph nodes, does worse. So this is Mark Moncrief's slide. I think it's an excellent slide, so I've just wholeheartedly stolen it. I apologise. So this is his summary. This is a summary he put when he was discussing the melanoma, the melanoma focus consensus day. And he said that people with basically positive sentinel node biopsies will fall into 3 categories. They will fall into the observe, they'll fall into the surgical category, and they'll fall into the systemic therapies. And these are his thoughts, and I agree with them, but not definitive, of how this might go. So essentially, if your sentinel node is positive, you should be speaking to people about your options for treatment. And your options of treatment are do nothing, consider surgery, and hopefully, in the near future, consider therapy. Interestingly here, so we're back to the head and neck again. And most people, and this could be a bugbear, and I think for next year we'll get Matt Potter to talk about head and neck, perhaps. For this area, it's too tricky, it's too difficult. It's actually one area where you should be considering, in my opinion, completion lymphadenectomy to get local control. Because if you lose local control in the head and neck area, it is disastrous. So I think that's the most difficult areas where the area we need to concentrate on. So the next 4 slides are individual considerations for each individual patient that you should be talking about when you say, are we going to talk about surgery or not? And in Oxford, what we do is, obviously, the sentinel node positive patients come back and they will see me or one of my colleagues. We will say, right, one of your options is surgery. We will explain surgery to them. But before you do that, you're going to see our oncologists, and they're going to give you what the other options are. And so you go off and see the oncologist, and then you come back and see your surgeon afterwards. So you get 3 consultations with all the views and opinions and your outcomes and stratification, because that's how it should be done before you go. Unless you can get to see everyone in one clinic, which would be fantastic. So as I was talking about, so this is the amount of how much disease do you have in your sentinel node? How many positive nodes do you have? How many negative sentinel nodes do you have? Because if you take things out in order, so that's the hottest node, that's the next one. So nodes 1 is negative, the next one down is, node 1 is positive, the next one down is negative, the next one down is negative. Is there a lot of point taking a lot of lymph nodes out of the basin, as I've said before? But your whole aim is, if you've got a lot of melanoma in the local area, is it worthwhile considering surgery to reduce the chances of anything coming back in that area? And this is an often discussed point. The patient sat in front of me, well, what's the chance of it coming back? Well, there's probably a pretty reasonable chance in your particular case of it coming back. So what do I do? Just watch and wait for it to come back? Well, we could consider other options. What's the most I can do? What's the least I can do? What are the benefits of doing that? What are the disadvantages of doing that? Ultrasound monitoring all sounds really great, and it is. What's the availability? I mean, I haven't even dared to raise it to our radiologists yet. I mean, I think they would probably all resign if I said, we're going to just sling everybody in for ultrasound monitoring every 3 months. So there's huge resource issues. Ultrasound is very person-specific, and of course you might be in monitoring with different people doing your ultrasound. It's easy in slim people, it's less easy the fatter people are. It's hard, oh, dreadful spello, sorry about that. Geographical challenge, so not so much in this country, but if you're having to drive 200 miles, 100 miles to have an ultrasound down every 3 months in a high risk patient, some people would say, look, I can't be bothered with all of that stuff, I just want you to do a procedure and we'll get it out of the way. And compliance, are people going to turn up? You know, they actually want to come and have all of that done. Some people don't want to come, they don't want to come for visits. So ultrasound monitoring, all the things you need to consider for that. So you have to, when you're considering surgery, you have to work out what the risks are of doing it. So what are the other diabetes, any other medical problems? Are they going to have, is the anaesthetic a risk? So even if they're a high risk for recurrence, do you really want to be doing the surgery? Is age an issue? We're not ageist. But you tend to get, you know, as people get older, they tend to be a bit more, less chuck it all at it and stuff the consequences, more, you know, if you do this, what are the downsides for me living my life now? I think people just mature as they get older and say, well, I prefer to, I don't want any risk of leg swelling because that will affect my golf, and I'm enjoying it at the moment, so don't worry about it. Immunocompromised patients, remember this group of people, if things go, if they get local control, it can progress very fast. So if they get more lymph nodes back in a regional basin, you don't want to be losing control of that, so you have to be on it. And there's lots of preferences. You know, I had some people sat in front of me and said, I'm 42, I've got 3 kids, you're chucking everything at it. I don't care, I know what you've told me about the complications, I know you've told me there's no evidence, I know you've told me this, but I want you to put every single thing, I'll have that and I'll have that. So there was a lot of it is patient preference. And if somebody sat in front of me and said, this is what I want to do, then I would do their operation because that's their choice. Again, with adjuvant therapies, and I've got 10 more minutes? Oh, nearly finished. That's all right. So adjuvant therapies, I wouldn't, do you know what, I wouldn't want to talk to anyone about the pros and cons of adjuvant therapies. It'd be like a vegetarian talking about the benefit of a pork chop. It wouldn't be correct. Nor should I think that oncologists should be giving you the pros and cons of surgery, because it's like a beef farmer talking about corn. So, so I think this is really exciting, but again, some people they'll sit and have the talk about the adjuvant therapies, and they'll have other talk about the surgery, go, I don't fancy that much. They'll go and have a talk about the adjuvant therapies, go, I don't fancy that much. And then they might decide which is the one they don't fancy much the least, if you see what I mean. And so what is the availability of adjuvant therapies? Where do people live? Is it something they can comply with? Various other things. So I think we have to keep everything on the table. So we've talked about this, the features of the melanoma primary. So the thicker, remember Rebecca said, the thicker tumours, things that are ulcerated, certainly ulceration is coming more and more. I mean, we knew ulceration was significant, but I think it's becoming more significant. People with microsatellite. If you, regards your sentinel node, you might say, well, this is a sort of disease that actually we need to start thinking about treatments that affect the whole body, not treatments that just affect one area. So those people are much more likely to need adjuvant therapies if they're going. And obviously, if you've got disease elsewhere, then the local surgery has a role for control, but isn't something that you would necessarily discuss quite so much. So, I mean, we're on slide 5, and this is in a consultation. So. And considerations, what's the site? So we often have this, what are the pros and cons of doing a completion lymphadenectomy in the axilla? Well, for most people in the axilla, it's a fairly stormy few weeks, and then it settles down, and most people don't have any ongoing problems except for numbness. However, in the groin, the risks of ongoing problems are higher. In the head and neck, they're virtually minimal if it's done properly in a specialist centre. There are relatively few ongoing long problems, except for numbness. Oh, yeah, sorry. Armpits, groin, head and neck area. Sorry about that. So, and the other considerations are the downsides of the surgery. What are all the complications? How long is it going to take me to recover? I don't want to spend another 6 weeks in hospital coming back to your clinic. I've had enough. I don't want to do that anymore. And then we talked about lymphedema. And the only thing to note is your risks of lymphedema, which is the thing that people hate the most, with good reason. If you do a dissection with microscopic disease, i.e. sentinel node positive disease, the risks of lymphedema are significantly less than if you wait till you feel lumps. If you wait till you feel lumps, your risks of complications are higher. Hopefully, if you pick things up on ultrasound, it still counts as that. So that's the whole point of ultrasound. It's better than fingers, so it should pick things up earlier. So, in summary, completion lymphadenectomy in 28, well, we're about to have a consensus document that's going to be produced, giving us all advice about what to do. It should be discussed as an option, because it is an option for treatment. The risks and benefits need to be discussed, but this is, to my mind, this is a very personalised decision that you cannot make just on a broad brush. You cannot look at a document and go, right, now we're doing this with that. This is an option that everyone should have discussed with a surgeon, with an oncologist, often with their clinical nurse specialist. And this is a multidisciplinary decision to be made. And it's a tricky one, and people do hugely vary across the board. Thank you very much.